Today, we are going to talk about arrhythmogenic right ventricular cardiomyopathy, which is an inherited cardiomyopathy characterized by progressive replacement of right ventricular myocardium with fibrous and fatty tissues. This weakens the ventricular walls, predisposes to ventricular arrhythmias, and it increases the risk of sudden cardiac death, especially in young adults and the athletes. The genetic case this is autosomal dominant inheritance with variable penetrance, the most commonly due to mutation in desmosomal proteins. Then pathophysiology, this defective cell-to-cell adhesion causes myocyte detachment during mechanical stress. This myocyte death occurs followed by fibrofatty displacement. This damaged myocardium creates areas of slow conduction leading to re-entry ventricular tachycardia. Clinical features, palpitation, syncope, especially during exercise. Ventricular tachycardia, sudden cardiac death. Some patients later develop right-sided or biventricular heart failure. ECG findings shows T-wave inversion in V1 to V3. Epsilon wave, a small positive deflection at the end of QRS wave in V1 to V3. Prolonged terminal activation duration. Ventricular tachycardia with left bundle branch block. The morphology indicating origin from the right ventricle. Investigations, ECG, Holter monitoring for ventricular arrhythmia, echocardiography, right ventricular dilation and dysfunction. Cardiac MRI. This demonstrates right ventricular enlargement, wall motion abnormalities and fibrofatty infiltration. Genetic testing should be done. Endomyocardial biopsy is occasionally done. There is a diagnostic criteria. Diagnosis is based on 2010 revised task force criteria, which combine structural abnormalities, tissue characterization, ECG abnormalities, arrhythmias, family history. Management is we need to avoid the competitive sports and strenuous exercise. Beta blockers to reduce the arrhythmia. Sotalol or amiodarone in selected patient. Implantable cardioverter defibrillator for patient in high risk for sudden cardiac death. A high yield exam point, young athlete with exertional syncope or sudden cardiac death. Think arrhythmogenic right ventricular cardiomyopathy. Fibrofatty replacement of the right ventricle is the hallmark pathology. Epsilon wave on ECG are highly suggestive. Ventricular tachycardia usually has a left bundle branch block morphology because it originates in right ventricle. Cardiac MRI is the preferred imaging modality, while ICD is the most effective treatment for preventing sudden cardiac death in high-risk patients.